Test.
Test, test. All right, so today we're going to be focusing on depressive disorders. This is the session ID for Turning Point. If you guys want to go ahead and log that in, got another bunch of questions for you today. Okay, so the recommended reading is just from DePiro. Again, nothing really else for that. The lecture objectives, so like you guys saw in the pre-recording lecture, we focused mostly on the first two objectives, and then the worksheets focused on the third objective, and then in class today we're going to focus on the next two. So by the end of this lecture, in addition to having or being able to do the first two objectives, you'll also be able to recommend treatment plans for depressive disorders of variable severity and list safety and efficacy monitoring parameters specific to a treatment plan. So on to the questions. So Jane is an otherwise healthy 30-year-old female who presents to the emergency department reporting suicidal thoughts. She reports depressed mood, feeling anxious and agitated, having difficulty concentrating, feeling worthless, and having difficulty sleeping. She reports that these symptoms are very intense right now, states that they happen off and on, but that yesterday was a really good day, and she felt happy. So is Jane having a major depressive episode? Somebody volunteer. You say no. Why? 3 months. What's the time frame for a major depressive episode? 2 weeks. Yep. So if yesterday she was happy, then today and she feels terrible, it's actually not a major depressive episode at all. This is actually more indicative of something we call personality disorders, where people tend to feel, in certain types of personality disorders, where people have very large mood swings and feel really terrible one day and feel great the next day, and a whole bunch of gray space and black and white in between. So don't worry, I'm not testing you on personality disorders. This is just to kind of get you thinking more critically about when somebody tells you that they have a whole bunch of symptoms, instead of thinking, okay, they automatically have depression, maybe what else could be going on, or maybe it's not necessarily depression. So can somebody describe the kindling effect? I'm just going to point at somebody. You. Huh? Oh, you guys have it? Well, then tell me it out loud. Exactly. Does that make sense to everybody? So what happens in depression is that you'll have, maybe your first episode of depression is when you're 20. And for the first 20 years of your life, you didn't have any depression at all. And then maybe you get better from that episode of depression. Maybe you didn't need medical treatment or anything, and it just kind of resolved after a few months. And then you have another episode of depression when you're 24. And then that one kind of gets better. Maybe it takes like a year to get better from that one. And then the next one is at like 26. And you start having more episodes happen more frequently, and each time that they happen, they get more severe and they take longer to recover. And this definitely happens without treatment, so without medication treatment, without psychotherapy. But we can also see this even when we do try to treat with medications and therapy a little bit. So there's the answer there. So which of the following has the longest half-life? And this one will be a turning point question. Are the answers on this too? It was just the other one? Okay. So citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, or sertraline. All right. Oh, of course, I don't have the option. Whoops. Okay, so everybody said C, which is fluoxetine, which is true, and it's good that I didn't have the ability to test you on answers E or F, because those are not true. Can I change it? Oh, nice. Okay, thank you. So the answer is fluoxetine. So for the shortest half-life, let's change that. So which of the following has the shortest half-life of those 6? Okay. Oh boy, all over the place. Okay. So a lot of variability here. Most of you guys said paroxetine, and that is the one with the shortest half-life of the 6. That's the one that we're familiar with having the worst withdrawal symptoms. If somebody just misses 1 dose, they'll have really terrible withdrawal symptoms right away, which usually feels like a weird headache, kind of like a zapping feeling, kind of going across the brain, and overall just general feeling very anxious and not very good. Was there something in the pre-lecture slides that made it look like the others were shorter? Go for it. Oh, okay. Well, that makes sense then. So I guess for the purposes of this, remember that paroxetine has the worst withdrawal symptoms, and we hardly ever use fluvoxamine, which is also called Luvox. So think of it for lecture and CDM for paroxetine is the one with the shortest half-life of the ones that we use and the one with the worst withdrawal. Any questions about that? Okay. Okay. What is the #1 precaution with bupropion? Seizures, yes. Is that one in there? Okay. So for treatment approaches, before we get in, I'd like to kind of cover what the differential diagnoses might be when we're concerned about somebody having depression. So when I say the term differential diagnosis, what does that mean? I know Dr. Carlson covers differential diagnosis in her lectures, so you guys have seen this before. Right. So making sure that we're considering all of the possible diagnoses that could be at play here. So it's the process of differentiating between 2 or more conditions that share similar signs and/or symptoms. So when it comes to depression, there's a bunch of other medical problems and psychiatric problems that could be taking place that might also present similar to or have symptoms similar to the symptoms of depression. So things like anemia, where people feel really tired and run down. Substance or medications, other medications can cause symptoms of depression. Thyroid disease, being specifically hypothyroid when things you feel pretty tired, appetite might be off. Infections, cancer, like I said, other psychiatric or neurologic disorder. Vitamin D deficiency can cause lots of symptoms of depression, and sleep apnea can also. So there aren't very great guidelines when it comes to treating a lot of the psychiatric illnesses. The most recent ones within the states are the American Psychiatric Association's 2010 guidelines, and this is still pretty much what we follow to this day. So there are a lot of options when it comes to first-line meds. If somebody kind of has more of like mild to moderate depression, and it really doesn't seem like maybe it's starting to impact their life a little bit, but not terribly, you really want to try to get them into therapy, because there's a lot of stuff that they could do behaviorally and then cognitively, like we talked about with the insomnia. We can do that cognitive behavioral therapy for depression too, where we try to get them thinking differently about kind of how they see the world and how they're interpreting their experiences. So if we can get them into therapy, a lot of times we can kind of resolve a lot of things that are happening without needing a medication, but sometimes we may add on a medication anyways. And the medications that are first line, you'll notice these 4 are in this list. So an SSRI, an SNRI, bupropion, or mirtazapine. In moderate to severe depression, you definitely want to start an antidepressant. So these are people who their life is definitely being impacted by their symptoms. Maybe they're having thoughts of death or suicide. They're not getting out of bed. They're missing work. They're having difficulty in their family and friendships and relationships because of their symptoms. And then you really want to encourage them to get into psychotherapy because while the antidepressants will help with the symptoms, there's so much that goes into depression when it comes to the types of behaviors that people end up kind of adopting, which is that whole like not getting out of bed and really thinking that like you kind of like walk through the world with like a cloud over your head, and it's like you have sunglasses on and you can't see like the light of day. That's what it feels like when you have depression. And so there's so much where you just kind of think negatively about everything. If you look at a cup, you'll say that it's half empty, and you'll never say that it's half full. And so much of therapy is really about getting you to think differently about things, and that's stuff that medications aren't really that great at. So if depression also is co-occurring with psychosis, so lots of times what can happen is in incredibly severe cases of depression, people will start to develop psychotic symptoms. We'll talk a little bit more about what psychotic symptoms are when we get to the psychosis lecture, but a lot of times what will happen in people with depression is that they'll have these like really negative hallucinations, like where they'll be kind of like hearing voices that are saying, you know, your wife's cheating on you, or you're going to get fired from your job. There's people that are following you, or there's people that are looking out for you in your workplace, and they're tapping your phone lines, and they don't trust you. And it's these kind of very odd and they call them like perseverative hallucinations, where people are kind of being like tracked or followed or something along those lines. That tends to happen more commonly in a psychotic depression. When you have psychosis with depression, we need an antipsychotic because the antidepressant's not going to touch that psychosis. So what we typically do is we'll start an antidepressant, and then we'll also start an antipsychotic as well. And we'll learn more about antipsychotics when we get to the psychosis lecture, but just know that they can be used in combination. And then for severe and refractory, so this is somebody who maybe had a suicide attempt, gets admitted to the hospital. They've been trying maybe a couple different medications, or they're trying to do something to get them more engaged. Or maybe they're in a state of catatonia, which is that they aren't responsive. Well, depending on the person, lots of times catatonia could mean like they're not even opening their mouth. They won't even move. They'll just be laying in bed. They'll be like going to the bathroom in bed. Like there's a whole bunch of things that happen with catatonia that are very dangerous. It's considered a medical emergency. And one of the first-line treatments for that is electroconvulsive therapy, or ECT. So it's not like what happens in some of the things that you see on TV, like One Flew Over the Cuckoo's Nest, which is like before my time, so I know it's before your time. But don't go to that movie to figure out what ECT is. I think that I know that I put something on Blackboard under like supplemental materials or something, which is a video of somebody getting ECT, and it's just a really kind of helpful way to see, okay, this is what happens when somebody gets ECT. So that is absolutely indicated in somebody with very severe depression, and interestingly, it's also indicated in somebody who's severely depressed who's pregnant, because it's considered to actually be safe. So second line would be, so you've tried a medication and it didn't really work after a period of time. Well, what do we do now? You can either add another medication on, another antidepressant that maybe has a different mechanism of action. So maybe you do an SSRI, which we know inhibits the reuptake of serotonin. And then if you want to try to add something else on, sometimes people add on bupropion, which doesn't touch serotonin at all, but touches norepinephrine and dopamine. The other thing you could do is just switch, do a totally different medication. So scrap the first one and then try a new one. But every time you switch or every time you add on, remember that you have to wait a good like 4 to 6 weeks to see if there's a beneficial effect there. When it comes to, so after you failed 2 first-line treatments, then you start to get into the maybe some of the older antidepressants that we see. So these are things like a tricyclic antidepressant, and you can experiment around with those, or certain types of augmenting medications, which we'll get into later in the lecture, but things like lithium or T3, which is triiodothyronine. And then for very treatment refractory depression, so we've gone through all of these things. This is probably like somebody's been in treatment for maybe a couple of years and things just aren't getting better. You'll try an MAOI, which is a monoamine oxidase inhibitor, which I'm not even teaching you because I hardly ever see those anymore. Or ECT again. So this is somebody who's failed all of these treatments, but maybe they're not catatonic, and they'll try ECT. So like I said, in general, you'll want to go after psychotherapy, antidepressants, or a combination of the two. The first line options are selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, bupropion and mirtazapine. And an adequate trial, somewhere between, this says 6 to 8 weeks, which is pretty accurate. Some people will say 4 weeks is an adequate trial. I don't believe that 4 weeks is an adequate trial. But you should see something changing after 4 weeks of being on this medication. There should be some indication that things are getting a little bit better. Some of the medications require a titration, and I uploaded a Clinical Pearls document that says like the lowest effective doses of each of the main medications that we use for depression. And what that means is like that's the dose where like you should expect to see some sort of inclination that some symptoms are getting better after 4 to 6 to 8 weeks of treatment. If somebody has an anxious depression, which we'll talk about too when we get into the anxiety lecture, you may want to start at an even lower dose, and that's also in the Clinical Pearls document. So you would go to like half that lowest effective dose. So you wouldn't even expect that anything would happen there. You wouldn't expect to see a benefit. But then you would increase the dose after a week or 2 weeks to the minimally effective dose. And then the clock doesn't start until you get to that effective dose. So if you start somebody on 10 milligrams of citalopram a day and you wait 6 weeks and maybe they've gotten a teeny weeny bit better but really not, they never got to an effective dose in the first place. So you really need to increase that dose to 20 before you should expect to see any sort of difference. So what do we expect to see in this time period of starting out an antidepressant? So after the first few days, sometimes you can see a little bit of reduced agitation or anxiety. A lot of times these kind of co-occur with depression. And you may even see a little bit of improved sleep and regulated appetite. So a lot of times people with depression are either eating way more than they're used to eating or they're eating way less than they're used to eating. And sometimes you can see that start to normalize even within the first week. After about 1 to 3 weeks, you'll start to see an increase in activity, like they're getting out of bed, they're taking a shower, increased sex drive, improved self-care. This is like washing their face, brushing their teeth, increased concentration, memory, and thinking. And then after 2 to 4 weeks, you might start to see, people might start reporting some improvement in their actual depression. Typically that takes a little bit longer. But also their return of being able to experience pleasure. Because when people are depressed, it's fairly common that they're not able to like laugh the way that maybe they used to, or that they're used to laughing. They're not able to enjoy pleasurable things like going for, I don't know, a pretty walk in a garden or something. They may do that when they're depressed and like not see the colors as brightly as they would if they weren't depressed. And so after maybe a month or so of being on an antidepressant, they might start to be able to realize the pleasure in those things again. They should have fewer hopeless feelings and a reduction in suicidal thoughts or thoughts of death. So for an adequate response, and that's so responding to an antidepressant means a 50% reduction in symptoms. So that should, if it's been 4 weeks and somebody's had a 50% reduction in symptoms, you would continue at that same dose and then keep evaluating. You'd evaluate it so 2 weeks after that 4-week mark, so at 6 weeks, 8 weeks, and 10 weeks. Ideally, you're evaluating every 2 weeks up until somebody's been on it for about 2 to 3 months. That never happens. A lot of times, like primary care doctors will start somebody on an antidepressant and they'll say, I'll see you in 6 months, let me know if something bad happens, which is terrible. If somebody's depressed, this is one of those times where I said this in the pre-lecture. I mean, we're worried about their own personal safety. A lot of people with depression have thoughts of suicide and actually attempt suicide, and we can't risk that. So when people are depressed, we actually need to be having a close follow-up with them, and we need to be reaching out to them more often. So this is what I have on the slide is what's ideal follow-up in these situations. if somebody doesn't respond very well, so maybe they have what's called a partial response, so it's some response, but not that 50% symptom reduction within 4 weeks, then we can increase the dose. So usually we'll start off at maybe that minimally effective dose, and there's usually quite a bit of room for us to continue increasing. So we can increase the dose. We can add another agent, which I'm not a big fan of. I'm a big fan of kind of maximizing the dose of one medication first and then waiting to add on another agent until we figure out whether that first one is effective if we optimize the dose. Or we can change to a new agent. Again, I'm not a big fan of that because if somebody's had some sort of response to something, we might as well see that whether or not they'll respond if we actually optimize their dose. If they have no response at all, so it's been 4 weeks, they started citalopram, they've been at 20 milligrams for 4 weeks straight, and there's like no response whatsoever, then I would normally switch to a different agent rather even than adding on another one. Because if there's no response whatsoever, it's likely that they're probably not going to respond to that specific agent. The interesting thing with antidepressants is, and like I talked about in the guidelines, just because, so the first two things that you're going to do are still going to be first-line antidepressants. So just because somebody doesn't respond to one of the SSRIs or one of the SNRIs doesn't mean they're not going to respond to a different one. Everybody responds to these medications differently, and they tolerate them differently. And so you can start somebody on citalopram, go 4 weeks, they have no response or they don't tolerate it well. Say, okay, let's try fluoxetine now. And then when they try fluoxetine, they actually respond and everything goes great. That really does happen in real life. And so it's important to keep that in mind. It's not like they've tried one SSRI that means, and like failed it, that means all the SSRIs are going to fail. It doesn't work that way with depression. Yeah. Great question. So the question is, if somebody does have a 50% reduction, but they still have 50% of their symptoms, and it's been 4 weeks, and we're continuing to check up on them, should we just be expecting that they stay at that 50% symptom reduction, or should we be expecting the symptoms to continue to get better? Ideally, we would be expecting the symptoms to continue to get better over time. Sometimes that takes additional, like the addition of therapy, and that the medication might not be doing the full or carrying all the workload there. Other times, if it just stays at 50% and that's kind of like all we're going to get out of it, if it's been 8 weeks, then we can consider adding something else on. But if there was a definite symptom reduction like that, I would keep the first medication and add something else rather than change that medication out to something new. Does that make sense? Okay. Okay. So treatment phases. I talked about this in the pre-lecture, but this is just to kind of go over the actual medication decisions that you would make throughout the treatment phases. So in the acute phase, you'll choose the med based on a variety of things. One of the biggest predictors of a positive treatment response is that the patient prefers to try that medication. So if the patient comes in the doctor's office and says, "Doc, I want to try Zoloft," it's probably a really good idea, if everything else is fine, for that person to start sertraline, which is Zoloft, for that person to start Zoloft. Because they've done studies and found that when people prefer to start a medication, the likelihood of them succeeding on it is actually higher. There's certainly some placebo that's involved in that, but that doesn't matter. In this case, especially when it comes to psychiatric illnesses, if whatever makes a person better, just go with it. If somebody's had a prior response to a medication, so maybe they were on, oh, go ahead. Well, probably both. So if somebody believes that something's working or something's going to work, they're probably more likely to take it, like religiously take it every day. And if they take it every day, it's more likely that it's going to work. So there's probably a combination of both of those things. So if somebody, so say the same person had anxiety before, maybe 10 years ago, got it resolved, everything was going better, and then 10 years later goes back to the doctor and says, "Doc, I have this depression. I took Zoloft for it 10 years, or Zoloft for anxiety 10 years ago. It worked really well. I tolerated it really well. I think that I should take Zoloft again. It's likely also that they're going to respond to the Zoloft again for depression. And what you'll see is when we get to the anxiety lectures, we use a lot of the same medications for both anxiety and depression. And that the SSRIs and SNRIs are all first line for both anxiety and depression. So if they responded to one of these medications some time ago, the likelihood of them responding again is quite high. Family history, so if another family member took a certain medication, it's more likely that the person, their family member, would also respond to that same medication. We would consider the safety profile, so something like mirtazapine, which has a lot of weight gain, is not something that we would prescribe to somebody who is struggling with diabetes, hyperlipidemia, maybe has some risk factors for heart disease and stuff. Adverse effect profile, safety and adverse effect go hand in hand. Comorbidities, that also kind of comes together, like I just said, in somebody who's at risk for cardiac disease. We would avoid certain meds. Drug-drug interactions, of course. PK parameters, and this comes into play when we're talking about those things like withdrawal. So fluoxetine and paroxetine, which is Paxil, and venlafaxine, which is Effexor, both of those tend to have the worst withdrawal symptoms. And when you stop them abruptly, people will notice symptoms like right away. With it, like at the time of their missed dose, they'll start having withdrawal symptoms, and they're really uncomfortable. So we tend to not use Paxil as much unless somebody has a lot of anxiety and a lot of difficulty sleeping, because it tends to make people a little tired. That being said, it does work really well, kind of the same way that the other ones work, if somebody is committed to sticking with it and isn't at risk of poor compliance. Okay, and then cost, of course. So after about 3 months, if somebody's had this clinically significant improvement in symptoms, then we go into the continuation phase, which is the next 4 to 9 months. So in the continuation phase, you would continue at the same dose that the person responded to within the acute phase. And then within this time, we would expect there's a huge variety of relapse risk. As you can see, somewhere between 20 and 85% of people. So this is, if you stop the medication, your risk of relapse is somewhere between 20 and 85%. So we generally say, don't stop the medication before you've been on it for 9 months, because your chance of relapse could actually be quite high, and you could have all of these symptoms come back all over again. So then you go into the maintenance phase after it's been that 9-month period. And maintenance on the medication is recommended for people who tend to have more chronic depressive symptoms. So this isn't like the depression came out of nowhere. This is like people who may kind of seem depressed overall for a longer period of time. And then maybe they have a major depressive episode where they meet all of the major depressive episode criteria. Or in people who have a history of 3 or more major depressive episodes. Once you've had 3 or more major depressive episodes, and you guys might remember this from the pre-lecture, you're at a 90% chance of having another major depressive episode. And because the risk of suicide and death is so great in people who have major depressive episodes, we then get into preventative or prevention mode, and we need to now prevent people from experiencing this depression. And so we'll say that they should be on lifelong therapy. Other things to consider within the maintenance phase are if people have residual depressive symptoms, and this would be that they're continuing to feel depressed even though they've been on an antidepressant that they've somewhat responded to. And this is when we'll toy around with adding and taking away other types of medications that they may be on. Psychosocial stressors. So sometimes what will happen is somebody responds to a medication, things seem like they're going pretty well, and then they get divorced, and the world kind of falls apart around them. So we'll have to make sure that we provide them extra support, and it's not just about the medication that's helping them through that. It's making sure that they're in therapy, maybe having them go to group therapy and get more involved in some other things. Considering their family history, if somebody, if they're one of their first-degree relatives has also been on Prozac for their entire life, then it's possible or likely that they might need it for that long as well. And then the severity of their major depressive episode. So maybe somebody's only had one major depressive episode before, and now they're on their second. But in that one that they had before, they had a suicide attempt. And in this one, they also had a suicide attempt. At this point, we're not messing around anymore, and we're going to say they should probably be on medication for the rest of their life. So for treatment response, like I said, a response is defined as a 50% reduction in symptoms. But the goal is remission, and that means complete absence of depressive symptoms. So predictors of remission are being of female sex, being employed, having a higher education level, having a higher income. And the things that, so these last three, those positive predictive factors all kind of feed into if somebody has achieved employment, higher education, and maybe the higher income, they've probably had they've probably dealt with some sort of struggles or difficulties earlier in their life that got them to where they are now. And that means that they have what's called resilience. And so that they can kind of fight through and make it through situations. And so while they may have developed some depressive symptoms, with some treatment and maybe some therapy, they can get through those, and then their chance of relapse or of not remitting is actually quite low because they have so many supports around them that have built them to get to where they are now. Whereas people who are more likely to not respond to treatment are people who've had a longer duration of their major depressive episode, so maybe it's been going on for a year before they ever sought treatment. People with other psychiatric and medical comorbidities, and people who in general have lower functional status, and maybe they don't have the supports around them that are going to help them get better. For monitoring and patient education, to monitor patients who start an antidepressant, you'll want to be evaluating their depressive symptoms, including suicidality. Can't ever forget people who have thoughts of suicide or potentially may have thoughts of suicide, and we need to be asking about that every time we see them. We want to ask them about their treatment adherence. We can't expect a medication to work if they're not taking it, so we want to make sure we have an idea of whether or not they're taking it. Tolerability and side effects of the medication, and then checking for any concomitant med changes to make sure we aren't introducing new drug-drug interactions. And then for patient education, you always want to tell people when to expect some sign of efficacy with this medication, because if they think that they're going to go home and they're going to take it at night and they're just going to feel all better, that's wrong, and we want to make sure that we're not making them think that. So we need to tell them it's going to take 4 to 6 weeks before things really start getting better. We also want to educate them on the adverse drug effects to look out for, monitor for abnormal bleeding or urination, and not to abruptly stop the medication. So the abnormal bleeding, just to explain, is related to the fact that platelets have serotonin receptors on them. And so when we block the reuptake of serotonin, that affects the way that our platelets work, and it makes it more likely that we could have potential or abnormal bleeding. So if somebody's on warfarin or is on any other anticoagulant or is on an antiplatelet agent, it's possible that they could be at increased bleeding risk. And then the abnormal urination is related to the fact that anything that affects serotonin can also have a side effect of SIADH, so syndrome of inappropriate antidiuretic hormone. And so when that happens, you would obviously have lots of abnormal urination, and you'd want to keep track of that. These two things tend to happen more commonly in the elderly population and less likely in younger people. Okay, so in somebody who has a partial or a non-response, unfortunately, about 2/3 of people will not achieve remission with the first agent that they try. So 66%, that's a ton of people. And it's really unfortunate, but it's the way that it is. And so we need to think about, well, how do we deal with this 66% of people who've tried an antidepressant who didn't really achieve remission? We need to think about what else is going on. So maybe there are some comorbidities that are at play. Maybe we didn't get them to an adequate dose. I think that's unfortunately one of the most common reasons, is that they just kept them at that citalopram 10 milligrams. Maybe they're not taking it. Maybe we have the incorrect diagnosis. So a lot of times this will happen fairly often, that people will have a diagnosis of bipolar 2, which is the bipolar disorder where people have more depression and maybe just have symptoms of hypomania, which we'll talk about when we get to that lecture. But what happens a lot is when they come to the hospital, it's because they're depressed. And people will think, oh, well, they're depressed, we need to start them on an antidepressant. And so they give them an antidepressant and they send them on their way. And then a year later, maybe something terrible happens within that time, but maybe they just stay on this antidepressant and nothing gets better. And the problem is actually that the diagnosis is wrong. And so bipolar 2 doesn't normally respond to antidepressants. It can increase the person's risk of going into a manic state, which is another medical emergency. But if they don't go into that manic state, it's just possible that they're not going to respond to it. And so maybe we have the diagnosis wrong and we need to really think about what else could be going on. Maybe there's adverse effects that are happening that are making the person not feel good. Other psychosocial stressors, like I said, maybe it's the person who got divorced and that's making them feel terribly. Or other types of PK/PD issues like drug interactions, or if they have a genetic mutation, that means it's eating up the drug and it's not getting to an effective dose in their body. So treatment strategy for so when we have these situations, partial or non-response, what do? You can switch the medication, which is preferred if a person's only had minimal symptom improvement after that adequate treatment trial, which is 4 to 8 weeks. You switch the med if there's no clear benefit of switching within class or to an agent with a different mechanism of action. So what that means is kind of like what I was talking about before, where just because somebody failed a certain agent doesn't mean they're going to fail a different agent within that same class. But that also means like you could try a different class. So you could go from an SSRI to an SNRI or bupropion, and you could expect to see a difference with all of those changes. It's not very clear one way or the other. Oops. When discontinuing or switching, it's probably safest to taper the first medication and then slowly increase the second medication. If you abruptly stop, you might see some of those symptoms of withdrawal, and so you want to make sure we're reducing the risk of that. But you also don't want to overlap it with the next medication because you could get serotonin syndrome, which can be dangerous and require hospitalization, but it's very rare. You could also, instead of switching, augment, so add on a second medication. And this is preferred if you have that, like what I was talking about before, if you have a partial response. So you do see maybe some symptom reduction, but it's not ideal. It's really not getting the person to feeling that much better. Then you add on another medication, and that might get them to feeling better. So treatment resistance, like I said, is quite common in depression. But even though treatment resistance is common, it doesn't mean that we should just give up. So if we've tried 1 or 2 medications and both of them failed, it doesn't mean that we just say, okay, you're going to fail everything, like good luck, see you later. We keep trying because it's possible that they will respond to something. These graphs are this is just the numbers that's on this graph over here. And what this is showing is the people who didn't have a response over a period of time in follow-up. So you have, without relapse. So this is like a Kaplan-Meier plot, and so it's time to relapse. And so step 1 means that this is their first medication. And so over time, you can see about 50% of people will relapse within 12 months after that one medication. And then with their second medication, so this is that they've switched from one medication to another one, about 30% of people will be without relapse. So 70% of people are going to relapse once they've gone from one medication to the next medication. And then after that, you can see that things kind of get murky and people are relapsing very commonly once you've gone to, like, now you're in the 3rd step and you're on to maybe your 3rd medication, or we're adding on things. It's very common that either you still have residual symptoms or you've relapsed. However, like I said, it doesn't mean that we stop trying. We just keep going and try to get the person feeling better. Any questions about this? Okay. So, patient case. Susie is a young lady. Her PCP learns that she's been feeling sad nearly every day for the past several months. She reports ongoing marital discord and financial stressors. She states she's been missing work because she can't motivate herself to get out of bed. She endorses reduced appetite and feelings of worthlessness. What should be Susie's PCP's first step? Should it be to check her thyroid function, to refer for a sleep study, to check a vitamin D level, or all of the above? Okay. Yep, so like I said, when we were talking about the differential diagnosis, there are a lot of other things that could be factoring into feelings like this. And so we want to make sure that her thyroid looks fine, that she's sleeping fine, and that she doesn't have like sleep apnea or insomnia, and that her vitamin D levels are fine. We could also check other labs, like do like a CBC and make sure that she's not anemic and that her blood levels all look fine, and maybe even get basic or a comprehensive metabolic panel just to make sure everything looks fine from the medical side of things. Because when we're considering psychiatric disorders, we want to make sure that we've ruled out all of the other medical diagnoses that could be causing these symptoms. So the answer is all of the above. Okay, so I think that I go through the treatments pretty quickly because of the pre-lecture worksheets where it got kind of like into the nitty-gritty for each of the medications. But just to kind of summarize, there are a lot of non-pharmacological treatments. I kind of talked about psychotherapy before. I'm not going to go through these videos, but I have posted them on Blackboard for you guys to look at, and they're just FYI if you're interested. So there's cognitive behavioral therapy, and I talked about that when we were talking about insomnia, where we change the way the person kind of thinks about their depression, thinks about how they see the world, thinks about, if somebody invites them to a party, whether or not they're going to say yes or no. Those are the kinds of things that will change through cognitive behavioral therapy. But then we also change their behaviors, and we try to get them doing more things, and a lot of the behavioral therapy is, especially with people with depression, is like getting them out of bed, getting them to take a shower, getting them to take a walk around the block, getting them to go to work. It's a lot of that, what we call behavioral activation, to get them kind of moving and going again. And then there's interpersonal therapy, which is not as evidence-based as CBT. CBT is the first line treatment for as far as non-pharm stuff goes. Interpersonal therapy is more of that like talk therapy where you kind of go lay on the couch and tell somebody about how your day went. But for some people that does help them feel better. I talked about electroconvulsive therapy. It's indicated in severe depression or when people have suicidal thoughts. It's also indicated in people who have depression with psychotic features or when they're catatonic, and as well as people who have treatment refractory depression. And what ECT does is not the best understood, but what happens is like somebody will present to a hospital or a clinic. They'll go into kind of like a procedural area, and they will be put under anesthesia for a brief period of time, and somebody will induce a seizure in them. So they'll have electrodes on their head, and they will induce a seizure that lasts somewhere between, I believe, 30 and 90 seconds. And that seizure, repeated over a couple weeks, usually they'll do like 10 10 visits within maybe a few week time period, starts to help that person feel better. ECT has a much quicker response than antidepressants do. People will start to respond within 1 to 2 weeks and start feeling much better, and their suicidal thoughts may go away completely within that short period of time. One of the downsides of ECT, unfortunately, though, is memory impairment, and so this is why we don't tend to use this as a first-line treatment, and we often don't use this in younger people because we don't want to be affecting their memory and cognition so early on. Then there are an assortment of other options. So vagal nerve stimulation is another one that's thought to be, it's also invasive. This is a picture. So they end up tying or implanting something that has little electrodes on your vagus nerve, and it'll stimulate the vagus nerve that somehow makes you feel less depressed. And then transcranial magnetic stimulation is less invasive. It's another one where you go into a procedural room, but they have like a magnet machine, and the video explains it pretty well. That's like passing magnetic frequencies through each other. And somehow, like I say somehow because we don't fully understand how these things work yet, but some people will report improved depression symptoms. And then bright light therapy is pretty interesting. People will get a box, it's like this big, and it shines really bright light, like sunlight, bright light on them. And the way that it works is people are told to figure out a way to like sit at a desk for 20 to 30 minutes a day and have this bright light shine on them. And this really works in people who have seasonal affective disorder, which is basically meeting all of the criteria for a major depressive disorder, but it has this seasonal component where it almost always comes during the winter months when we have less daylight and we're seeing less sun. Okay, why don't we take a break and come back in like 5 minutes, so 9:35. Okay, let's get started again. So for antidepressants, you can see there are lots of classes of antidepressants. We'll focus on the main ones, and those are the ones that are also addressed in the pre-lecture materials. So the point of addressing these in lecture is just to kind of highlight the mechanism of action just really quickly, and then if you guys had any questions that are mostly about kind of the way that they work and stuff within lecture that maybe you noticed during the pre-lecture worksheets. So for serotonin, selective serotonin reuptake inhibitors, the way that they work is you'll have a nerve or a neuron coming in, and you have an efferent neuron, leaving, and that's how nerves talk to each other. Nerve cells talk to each other by releasing little neurotransmitters and then accepting neurotransmitters and then sending another response later on. So what happens is you'll have vesicles that have, and that's what these little things are, and they have certain neurotransmitters inside of them. So for these ones, let's just say these vesicles are all containing serotonin. The serotonin, or the vesicle, will adhere to the cell wall of the neuron, and the vesicle will kind of spew out the serotonin into that synapse. And within the synapse, you'll have a ton of serotonin. Well, in somebody who's depressed, you either have not enough serotonin, and maybe the vesicles just don't have enough serotonin and they're not releasing enough, or you might not have enough receptors on the efferent neuron to accept that serotonin and actually generate the adequate response that it's supposed to generate. So with selective serotonin reuptake inhibitors, they'll block. So the other thing that happens is, so when we have this kind of surplus of serotonin in here, there are reuptake receptors that exist on the afferent neuron, so up here. And so these receptors will then kind of eat up all of the excess serotonin that doesn't get used by the efferent neuron. So what happens with SSRIs is that they'll block those reuptake inhibitors so that it doesn't have the chance to eat up all of that excess serotonin. And so the serotonin just kind of hangs out in the synapse. And over time, the efferent neurons will start to they'll generate extra receptors. They'll generate extra serotonin receptors so that the efferent neurons can then start accepting and having the appropriate responses to the serotonin, which relate to mood and anxiety as they're supposed to. Does that make sense? Any questions about that? One thing I wanted to say, I just had a question and I wanted to clarify. Somebody asked me about knowing doses. So I realize that there are so many medications and that there are a wide variety of doses. So when it comes to the things to know, focus mostly on, within the worksheets, the stuff that you have to fill in yourselves. If there's something where you're like, well, one of these sources says this and another source says that, what am I supposed to do here? I'm not going to ask you a question on that. If it's too nuanced to where Micromedic says one thing and UpToDate says another thing and Lexicomp says something else, I'm just not going to ask you a question on that because it's probably something that we don't have a very clear answer about in clinical practice. And so there's no point in asking you a really pointed question there. The Clinical Pearls worksheet, or the little thing that I have uploaded that just has the starting doses or the minimally effective doses, those ones I definitely want you to know. Okay? Okay, so on to SNRIs. So they work almost the exact same way. So I'm not going to go through and explain all of the anatomy and pathophys here. other than just to say that within these vesicles, not only do you have serotonin, but you also have norepinephrine. And so you'll now have both of those neurotransmitters within the synapse, and then the afferent neurons, or I'm sorry, the efferent neurons starting to make more of the receptors for both of those neurotransmitters. And for bupropion, it's the exact same thing, except now take out serotonin because bupropion doesn't affect serotonin, but it does block the reuptake of norepinephrine and dopamine. So now within the synapse you have norepinephrine and dopamine, and the efferent neuron is making more receptors for norepinephrine and dopamine. And we're blocking the reuptake of both of those neurotransmitters. Okay, any questions on those three classes of meds? Okay. So for mirtazapine, works quite a bit differently. It works on serotonin in a bunch of different ways, and so it's not that clean, just reuptake inhibition. So we don't need to get into the nitty-gritty on the specific mechanism of action there. But the interesting thing about mirtazapine is that it has this paradoxical dose-dependent sedation. So what that means is what's depicted here. So as we increase the dose, we see more efficacy. But we also see this, at the lowest doses, we see a high level of sedation. So that's like 7.5 milligrams of mirtazapine will be very sedating in somebody, but it won't touch their anxiety or their depression. But if we increase the dose to like 15, that's what we consider a minimally effective dose for depression or anxiety of mirtazapine. It'll be kind of sedating, but not as sedating as the 7.5. You can increase, I think the label says the maximum dose might be 45, but we've used up to 60 before to try to get after that more depression and anxiety. But as you keep increasing, the medication becomes less and less sedating. Okay. So, then there are, you're really off. So then there are a whole bunch of other antidepressants that I don't personally feel like we don't use them as often as we use the other ones that we just talked about. And so I don't think we need to get into how they work and all their doses and all of the nitty-gritty about them. But just I want you to be aware that these exist and why we may or may not use them. So tricyclic antidepressants, if you remember from the guidelines, are those like third-line medications. So they kind of actually work very similarly to SNRIs, but they also have very strong anticholinergic effects. And so you get a lot of the sedation, blurred vision, dry mouth, constipation, all of that stuff with them. And so that kind of limits their use. We know that so there are a ton of tricyclic antidepressants, and within them, the ones that are tertiary amines, like amitriptyline, have more sedating effects than the secondary amines like imipramine. The monoamine oxidase inhibitors, like I said, we hardly ever use them anymore, and that's because they have a slew of not only adverse effects, but also significant, not just drug-drug interactions, but drug-food interactions that make it so that people have to actually limit what they eat. Like they can't have beer, wine, aged cheeses. There's just a variety of things that people have to limit from their diet. And so that's a big reason why we don't use MAOIs. But the way that they work is actually by increasing the levels of serotonin, norepinephrine, and dopamine, because all of those are monoamines. And so monoamine oxidase inhibitors will inhibit the breakdown of all three of those neurotransmitters. And then we have, so trazodone, I realize I'm skipping one here, but trazodone is a really common antidepressant that you guys might remember from the insomnia lecture. And so we use trazodone quite a bit for insomnia and hardly ever for depression because it's so sedating that people tend to like not be able to function during the day when we get to the doses that are actually effective for depression. Nafazodone's kind of like trazodone, but we don't use it very much at all because it has significant liver toxicity as a side effect. And so because the liver toxicity is quite common, we tend to avoid using it. And then vilazodone and vortioxetine are both newer antidepressants, and I just haven't seen them used much since they've been on the market. They're both like within the last, I think, 2 or 3 years have been approved, and so because they're both so new, I haven't seen them, and I don't really know how things are going with their efficacy and all of that. So with depression, we can't talk about depression without talking about some of the complementary and alternative options. And the biggest one, the most common one, is St. John's wort. And this is an over-the-counter product, so people can buy it in CVS and Walgreens. And it can be used for depression. If you look it up on the Natural Medicines database, it can be used for like 45,000 other things. But one of the most common things that it is used for is depression. It works kind of like an SSRI, so it does affect serotonin levels. So when people think like, oh, I'm just taking something natural, it's not a medication, it's doing the same things that the other medications have done, but it hasn't been tested and had the safety tests and randomized control trials that all of these other medications have had. So I usually try to steer people away from something like this. You don't have to worry about doses for St. John's wort, but the big thing is that it has so many drug interactions, and that's the reason I usually try to steer people away from it, because it can really affect levels of almost everything that people might commonly take. And there are a lot of adverse effects that you can see listed at the bottom of the slide here. So like I talked about before, one of the other things we can do when we get into maybe that third line where people have tried a couple medications and things are maybe responding a little bit but not working out ideally, you can add on some other things. So one of them is lithium. Lithium is a mood stabilizer that we'll talk a whole bunch about when we get to the bipolar lecture. But it also is used as an augmentation agent in people with severe depression. Most of the efficacy literature that we have is based on it being combined with a tricyclic, but because we know the tricyclics work so similarly to the SNRIs, we kind of extrapolate. And anecdotally, I can tell you that it does work really nicely when we combine it with an SNRI or an SSRI. We have to monitor plasma concentrations for lithium. We'll talk a whole bunch about that when we get to the bipolar lecture. So that's kind of a downside. It requires people needing kind of more close follow-up. But the amazing thing about lithium is that it's one of 2 psychiatric medications, of all of the psychiatric medications, that clinical trials have proven it has anti-suicidal effects. So people think about death less often. People attempt and commit suicide less often when they're on lithium. And overall, because of these features, we'll tend to use it in people who have severe depression, who are kind of actively suicidal or really thinking a lot about death and a lot about thoughts of suicide. Triiodothyronine, or T3, is another medication that can be used as an augmentation agent. I don't have a lot of experience with using this, but I've seen it used, and some people say it works pretty well. It's not to be used independently of an antidepressant. It should be added on to an antidepressant. You can see the dosing there. You don't need to worry about knowing the dose for that. But it can be used. The good thing is you don't need to test thyroid levels. You should test thyroid levels to make sure that the person's thyroid is working well and that's not the cause of their depression symptoms. But even if they have normal thyroid levels, you can add on T3 and see if you can get some additional benefit. And then antipsychotics, the ones that we commonly see used to combine with antidepressants, are aripiprazole and quetiapine at their lower, like the lower half of their dosage ranges. Obviously, we would use these if somebody has psychotic depression, like we talked about earlier. But even if somebody's just really struggling with depression and maybe they're developing things that don't seem full-on like delusions or hallucinations, but maybe it just seems like their depression's really getting out of hand and it's getting to that point where they're kind of perseverating on a lot of things, then you may consider adding an antipsychotic. So back to Susie. Her labs came back normal, and her sleep study determined she does not have sleep apnea. So what should Susie's PCP do? Should she start bupropion, refer for psychotherapy? Should she start an SSRI, or start an SSRI and refer to psychotherapy? Or should she do C or D? Remember, Susie had quite a bit of symptoms. Okay. Okay, for people who said refer to psychotherapy, what went into that decision? Without adding in an antidepressant. So people who said B. Go for it. Oh, interesting. Okay, so you were saying you thought B because maybe the PCP doesn't have the clinical expertise to be deciding on an antidepressant, and maybe it should be somebody who specializes in that field. Okay. Any other thoughts? Okay. So combining an antidepressant with psychotherapy because there's so many psychosocial stressors, so maybe she would get some more benefit from the psychotherapy and extra support. Okay. Any other thoughts? Yeah. Okay, good question. Okay, so the question is, yeah. Okay, good question. Gotcha. So you're asking, can a PCP or psychiatrist or anybody just write for a medication and not refer for psychotherapy? Like, can the person just be on a medication without psychotherapy? That's the question? And you're saying they can't. Okay, so this is good. No, this is great discussion. Okay, so Susie had a lot of symptoms. Actually, I would kind of, based on the list of symptoms that she had, I would say she probably had some sort of moderate, maybe even severe depression. And so I would think that she should use a medication to help with that. So I would have added on an SSRI or one of the first-line medications. I agree that psychotherapy is indicated every time for every single patient. I think that people who don't have depression also could benefit from psychotherapy. So I agree. Like whenever anybody has mood symptoms or is coming to their clinician to ask for advice, it makes sense to refer for psychotherapy. It's not required, though, and unfortunately a lot of providers don't think of it or they don't have the resources to be able to make that referral, and a lot of patients aren't interested. And so you'll hear a lot of patients be like, I'm not going to therapy every week. So that's what happens. As far as the psychotherapy, whether or not the PCP was an expert. So, and you don't need to be an expert to start an antidepressant. They're pretty straightforward. We're not starting antipsychotics or, mood stabilizers or anything. This is just an SSRI. PCPs do it all the time. I think PCPs prescribe like 70% of the United States, like SSRIs that are dispensed. So it's pretty common, and it's totally fine. And they're pretty experienced with their patients coming to them and telling them about mood symptoms and stuff. Good discussion. Any other questions about this? So I would have said, so either C or D, because, like I said, while psychotherapy is always recommended, a lot of times people don't take it. But I would have encouraged D as like the number one. That would have been the best option. Okay, so continuing with Susie. Her PCP decides to start an antidepressant and comes to you for advice on which one to choose. What would be the best recommendation? So let's do 4 answers. Oops. Okay, would you start bupropion, 150 milligrams by mouth for 3 days, and then increase to 150 twice a day? Would you start venlafaxine, immediate release, 37.5 by mouth twice a day? Would you do mirtazapine, 15 milligrams at night? Or don't start an antidepressant, just refer to psychotherapy first? We kind of talked about that a little bit. Okay. I think I know what this is going to look like. Okay. I thought that's what this would look like. So all of the doses are fine and correct. So there's nothing wrong there. I also said venlafaxine, and I can't remember the specifics, so let's jump to her case. Where is she? So she's been missing work because she can't motivate herself to get out of bed. So that right there tells me don't do mirtazapine because it's sedating. So this is where we start to think about the side effects and how we're going to pick certain medications. So that just, and we do this a lot in psychiatry where we kind of like rule out which medications we're going to pick. So we ruled out mirtazapine. We know that her depression's pretty bad. We want to start a medication, so we're not going to do just the psychotherapy. So C and D are now off the options. We can do bupropion or venlafaxine. She's been feeling pretty sad, marital discord and financial stressors, and she has reduced appetite and feelings of worthlessness. So bupropion also reduces appetite. And so we wouldn't want to further reduce her appetite. So this is where we get into like the nitty-gritty of these medications and how we pick them. So that leaves us with venlafaxine. The good news about venlafaxine, and bupropion is also like this, and fluoxetine is also like this, which is an SSRI. They all kind of activate people, so they make people feel a little bit more awake and alive and like wanting to get out of bed in the morning. And so you'll want to pick, in somebody who's having this kind of lethargic depression where they're staying in bed a lot, you'll want to try to pick a medication that's more likely to get them out of bed. So fluoxetine, bupropion, and venlafaxine. Now, what's the risk of what's something we don't like about venlafaxine IR? What's that? Did I hear something? The withdrawal symptoms. So with the extended release versions of venlafaxine, you don't actually see that as much, but you do see it with the immediate release. And so I just realized that I had circled both mirtazapine and venlafaxine, but in real life, I wouldn't do the mirtazapine because of the whole problem with getting out of bed thing. Yeah, really good question. So is she not getting out of bed just because she's depressed, or is it because she's sleepy? And it's because she's depressed, but when we add something that's sedating, it kind of just adds to that feeling, as opposed to, like, maybe in 6 weeks she might get better, but we don't want to, because she'll feel the sedation of mirtazapine right away. Day one, she'll feel that sedation. And so we don't really want to add to that. And people do report with mirtazapine that next day drowsiness, so it would make it definitely even harder for her to get out of bed. If somebody can't afford the ER version for some reason, yeah. Or if you work at the VA and IR is the only thing on the formulary. Okay. Next question about Susie. What monitoring or follow-up would you recommend to the PCP? 8 weeks when we would expect to see maximum effect. 3 weeks when we would expect to see maximum effect. 2 weeks to assess preliminary symptomatic relief, or 4 weeks to assess preliminary symptomatic relief. Okay, so for the people who said 2 weeks, tell me why 2 weeks. Not sure if it's going to work or not? Yeah, she could have adverse effects that we could see early on. Mm-hmm. Anybody else? Mm-hmm. Yeah. Mm-hmm. What about 4 weeks? People who said 4 weeks, thoughts on those? Why did we wait till 4 or not wait until 8? Mm-hmm. Sure. Yeah. Okay. So the bare minimum, we would like expect to see something. We would definitely expect to see some sort of improvement at 4 weeks. So I can tell you what's practiced and what's supposed to happen. So I think what's practiced is most of the time people will do the 4-week thing. What's supposed to happen, and I've worked in clinical situations where we did this and we were really religious about this, where you do check in at 2 weeks. For the adverse effects, you want to make sure that they're actually taking it because they're tolerating it and all of that. And also, if you remember from the slide earlier, we can expect to see a little bit of symptomatic relief within just 2 weeks. And we want to see that there's an indication of something getting better. So lots of times that's like a 5-minute phone follow-up. How are things going? Are you tolerating the medication? Have you noticed any change in symptoms? And then you follow up again in 2 weeks, and you should really see some changes by that point. So the answer should be C, even though unfortunately what happens a lot of times in practice is D. Okay, so special populations. In pregnancy and lactation, this tends to be a pretty hot topic because we have a lot of hormonal changes that happen when people get pregnant, and that can really affect our mood. So up to about a quarter of women, of pregnant women, will meet criteria for a major depressive episode. And about 70% will report some of the depressive symptoms, even if they don't meet criteria for major depression. And there's a lot of risks to not treating maternal depression. The baby can actually be born premature. You can have low birth weight. You can have fetal growth restrictions, so the baby's not even growing at the rate that they're supposed to be growing, and postnatal complications. Children of untreated mothers are more prone to emotional and behavioral stability, and so what happens a lot is if you have a mother who's depressed, she can't connect. She's not connecting with anybody, right? We talked about how it can be hard to like feel positive emotions and really, experience positive things, and so even if she's not connecting like with her significant other or with her family members, it's also very likely that she's not connecting with her baby. And in the early stages of life, that connection is critical. It's so important to the baby actually growing up and being just fine and healthy. And so you can have a lot of really significant adverse effects from not treating maternal depression. But the decision to treat maternal depression is always a shared decision. So this is not something like the doctor says, you're going to start sertraline right now. This is like the mother says, Doc, I don't know what to do anymore. I can't stop crying. I'm not getting out of bed. I'm not relating well with my baby. What do I do? And the doc says, you could start an antidepressant. And then they go through that decision together. There is a lot of controversy surrounding the risk. So sometimes it's the mother's actually, if she's currently pregnant, the risk relates to the baby will be dependent on an antidepressant. And we talked about how withdrawal is kind of not very comfortable for adults going through antidepressant withdrawal. So having a baby go through antidepressant withdrawal when it's actually born is also not great. And there's an abstinence syndrome that happens. And it's treated kind of just with supportive care. So the thing is we have to, again, weigh those risks and benefits. Are we willing to deal with all of these possible risks and not treat with a medication? Or can we treat with a medication knowing that we can medically treat the possible abstinence syndrome that happens with the baby and prevent all of these things from happening? Mm-hmm. Mm-hmm. It's huge. Yeah. So the question is, there's a lot of hormone changes that happen after the mother gives birth, and so how do you decide if it's just a normal, reduction in those hormones and that we just wait it out, or should we treat it medically? So there's two things to think about. One is mom is depressed or develops depression while she's pregnant, and that's, do we treat while she's pregnant? And the other question is, mom's maybe showing symptoms of postpartum depression. Do we treat that? So postpartum depression is a little bit, I think there's a separate, I think there's a therapeutic integration case on this, so you guys will get to really get into the nitty-gritty on it. But the thing just to remember is benefits versus risks, and it's a shared decision between the clinician and the patient. And so, yes, there is this period of time where with all of those hormone changes, something can happen like after the pregnancy, but that shouldn't last very long, like more than a couple days usually. And if it's continuing on beyond that couple days, because the bonding between mom and baby is so important, especially within that first week or month, that we really need to get mom like on board, like I'm going to be a mom, I'm going to do this right now, and I'm going to love my baby. And if that's not happening, we need to really intervene at that point. Any other questions about that? Okay. So for the risks, all of the SSRIs are pregnancy category C, except paroxetine is category D. They have found some fetal abnormalities in people who've been on paroxetine. Tricyclics are also all category C, except maproteline, which I've never seen used ever, is category B. And then all of the SNRIs, mirtazapine and bupropion, are all pregnancy category C. So if you'll remember, with the pregnancy categories, C is the one where you always have to say, like, risks versus benefits. Maybe we should use it, maybe we shouldn't. This needs to be a shared decision between clinician and mom. And then for lactation risk, you have doxepin and St. John's wort are contraindicated because they excrete into the breast milk at a significant level. All of the SSRIs and TCAs except for doxepin are L2, which is the somewhat safe, and you guys will talk more about that in the therapeutic integration. Bupropion and SSRIs are not well studied, and there are variable risks, or SNRIs rather. But again, this is that benefits outweighing the risks, vice versa. And then MAOIs should be discouraged as they've been shown to be teratogenic in animals. So for treating major depressive disorder in pregnancy, for mild to moderate major depressive disorder, you want to do just psychotherapy. And that's CBT is the more evidence-based psychotherapy, or you could do the interpersonal therapy. Moderate to severe MDD, you definitely want to start an antidepressant. If somebody's really having a lot of symptoms, not getting out of bed, not going to work, not doing the stuff that they're supposed to do as part of their normal daily life, then they really probably do need medication treatment. It's better to stick with just one antidepressant and try to optimize the dose of that than to start adding on a bunch of augmenting agents. You really want to try to simplify and minimize the exposure to the fetus to a whole bunch of different agents. So ideally, you would use the lowest effective dose. You would pick one that has fewer metabolites, one that has higher protein binding because you'll have reduced passage into the placenta, and then few drug interactions or food interactions and all of that. So back to Susie. She's been doing well for the past 5 months. Doc ended up starting mirtazapine, and apparently that didn't bother her sedation. She called her PCP to tell him that she's pregnant and she wants to know if she should continue her antidepressant. Should she? There are 5 answers. So no, due to potential risk to the fetus. Yes, because there's no pregnancy risk. No, because her depression is resolved, so she won't need it. Yes, because the risks of MDD relapse outweigh the risks to the fetus. Or E, it depends. E, it really just depends. This is everything I've been saying for the past 5 minutes, which it's a shared decision between the provider and the patient and considering the risks and the benefits. You could make a really good argument for the answer D, which if the risks of the MDD relapse outweigh the risks to the fetus, then she should continue mirtazapine. But ultimately, it depends on what they all decide to do. Okay, in the elderly, depression in the elderly sometimes can look a little different than in younger populations. It might not manifest as sadness in the same way that we're used to see when people come to their doctor and they say, I've been sad, I've been crying. The elderly, it might not look the same. It might be more of the reduced interest in or pleasure in doing things they used to enjoy. You can have cognitive changes where they'll have more difficulty with concentration, memory. They may have some confusion. And they're more likely to have a lot of the somatic symptoms, so like the insomnia, the decreased appetite, irritability, maybe some like pain-type symptoms. Their clinical course, unfortunately with the elderly, we're less likely to see people kind of quickly get into remission, and we're more likely to see, if they do get into remission, that they may eventually relapse. And unfortunately, there's a disproportionately high rate of suicides in the elderly, so they're more likely to attempt and succeed or commit suicide. So maintenance antidepressant should be strongly considered. So even if it's the first time they've ever developed depression, it's important to think this person should probably be on this for the rest of their lives. In general, geriatric depression can take a bit longer to respond to antidepressants than younger adults. Because geriatric patients tend to be a bit more sensitive to medications, we want to start at lower than the minimally effective dose. So in that Clinical Pearls handout that I have online, there's the minimally effective doses. You'll cut those in half and start there. Antidepressants should be chosen carefully to minimize drug interactions, as the elderly tend to be on a lot of other medications and side effects. You could consider non-pharm treatments with psychotherapy. So depending on the person, if they have a lot of confusion, they have a lot of memory impairment, they're actually not going to do well with cognitive behavioral therapy because it requires them to do a lot of thinking. And if they can't focus or concentrate, or their memory is really depreciated, then they're probably not going to respond to that cognitive behavioral therapy. And so you want to consider interpersonal therapy, which is more of that just talking things out. You could also consider ECT if things get particularly severe or treatment refractory. So for pharmacotherapy, this is another one of those situations where you prefer to optimize the dose of one medication instead of adding on a bunch of different medications. And instead of adding on, if they don't respond to one, just consider a switch to a new antidepressant. And if you do want to augment, really try to encourage them to go to psychotherapy instead of augmenting with a medication. So SSRIs tend to be the treatment of choice, but we do see the increased risk of SIADH and hyponatremia in the elderly, so want to make sure we're checking labs and checking their sodium levels. The tricyclics and the MAOIs really aren't recommended because they have so many adverse effects, and especially with all those anticholinergic adverse effects, they're really not recommended in the elderly. And occasionally you may see where the elderly are started on a stimulant in addition to an antidepressant, or maybe instead of an antidepressant. This is not my favorite method of treatment. However, if somebody's having severely lethargic depression and really having a difficult time getting out of bed, and they don't have any history of substance use disorder, you can start them on a stimulant, and sometimes that lethargy or lethargy kind of improves. So just a few other questions to wrap up. Which of the following agents is contraindicated? So an 18-year-old man is diagnosed with major depression. He also has idiopathic epilepsy. Which of the following agents is contraindicated? Bupropion, fluoxetine, mirtazapine, or venlafaxine? Okay. Wonderful. Most of you said bupropion, and that's the one that has the high risk or relatively increased risk of seizures. And so if somebody has a history of seizures, then bupropion is contraindicated. So the antidepressant action of imipramine, which is a tricyclic, which I realize is not in the slides, so I apologize for that, is thought to be caused by which of the following? So do tricyclics work by blockade of prejunctional alpha-2 adrenoreceptors, blockade of prejunctional neuronal, norepinephrine, and serotonin uptake transporters in the CNS, increased numbers of alpha adrenoreceptors, or inhibition of monoamine oxidase? Okay. So TCAs, if you remember from that slide that I had before, work very similarly to SNRIs. And so B talks about the prejunctional, which is like the afferent neuron, norepinephrine and serotonin uptake transporters. And so it works more like B, and they don't really have effects at alpha-2 adrenoreceptors. All right, which antidepressant or antidepressant class carries the least bleeding risk? Tricyclics, SNRIs, bupropion, mirtazapine, or SSRIs? There's 5 answers. Okay. Okay. So what is the risk of bleeding with antidepressants? Like, where does that come from? Serotonin. Why? Because there's serotonin receptors on platelets, right? And so which of these medications doesn't touch serotonin? Doesn't affect serotonin at all. Bupropion doesn't affect serotonin at all, so it has the least bleeding risk. Mirtazapine does affect serotonin quite a bit. All right, that's the end of lecture. Any questions? Okay, thank you all. Hi. Yeah.
The geriatric. So you said instead of add-on therapy, just change the medication if it's not working for partial.
Yeah.
So even if you see the 50%, just change the medication.
If it's so, a 50% is a response. So that's like
Yes.
that's definitely an improvement.